going to talk about lupus. Lupus is also an autoimmune disorder, but it can cause multitude of other symptoms, such as mouth, nose ulcers, lungs, kidneys. You can get the butterfly rash on your face, heart issues, blood issues, muscles, and joints. So here's just a picture that overall shows it's SLE, systemic lupus erythematosus. So what is this? It's a multi-system disease. We don't really know. We know it's autoimmune though, and we have to look at multiple labs and how the exam is in order to come up with the diagnosis and prognosis. There's some people that can have just skin lupus with a good prognosis and treatment, but there's people that end up with renal failure, and that is more devastating. We think that it could be caused from excessive autoantibody production, and it causes cytotoxic damage. So it's basically damaging the cells. It has to do with immune complex formation. And so all of this therefore then causes immune inflammation. And lupus, again, it's different areas of the body perhaps than rheumatoid arthritis because it's working in a different way, in a different inflammatory, or how it's damaging the cells. So how do they present? Look at that. We'll go back to the picture here, but most often they'll have the butterfly rash and muscle joints, aches and pains. Perhaps they'll have mouth and nose ulcers, but sometimes it's just hard to even pinpoint because they just have vague symptoms and they're tired all the time and just don't know what's going on. So yes, organ systems can be involved if they are presenting late in the game and they have a severe case of lupus. Then, you know, that's a problem, and we'll definitely find out that this patient is really sick. And it involves tissues, so you start having tissue damage due to the disease process. So how do you classify this? SOAP Brain MD is a mnemonic for those people, those of you that like mnemonics. So number one is, so a person is said to have lupus if they have 4 or more of this 11 criteria. They can have it simultaneously or not necessarily simultaneously when you're observing them, because again, sometimes it's hard to pinpoint whether it is a true lupus or not, so it's not always cut and dry. So pleuritis, pericarditis, oral ulcers, arthritis, photosensitivity, or rash, any type of rash, the malar and the discoid, hemolytic anemia, leukopenia, so anything wrong with the blood, renal disorders, antinuclear, antibody, ANA positive, immunologic disorders. So as you can see that there are multiple, more of a workup with this. And to go back to rheumatoid arthritis, let's just say your rheumatoid factor came back negative and you're really getting negative testing. This is when you can go on and get this anti-native DNA antibody, the Smith antibody, which is the anti-SM, antiphospholipid antibodies. Yeah, and so those would be your extra, as well as an ANA, although I usually order a rheumatoid factor with an ANA. You can also check for proteinuria and see if there's any casts. So here is a patient with weight loss, chronic psychosis, a rash. So as you can see, I just wanted to show you that you can get this type of rash. It can be red, it can be darker like this, and it depends on our skin color on how it presents. And if you're looking at the data here, labs, you'll see the protein is high in the urine, so they usually get a 24-hour urine. I don't necessarily always order a 24-hour urine on a patient. Sometimes we'll do that in rheumatology. But I definitely will get the SED rate, the CH50, the C3, C4, whoops, sorry about that, the ANA, anti-DNA, and you can also get a direct and indirect Coombs test and the anti-IgG. So most likely for testing purposes, you're not going to need to know all of these, but you just need to know that there is a further workup involved. And where you're working in primary care will depend on how deep you are going into all these CH50, indirect and direct Coombs. That's when you'd be talking to rheumatology, and they'd say, hey, can you order these tests, or I will take care of it in rheumatology. But really, your basic lab workup would be a CBC, a CMP, your SED rate, your CRP, ANA, go back to this one here, your ANA, your the CCP antibody, because you want to make sure it's not rheumatoid arthritis. And the moral of the story is it's a gray area. I wish I could tell you in primary care, this is what exactly you're going to order, because I know us as nurses and nurse practitioners want it clear, right? To say this is what we need to get, but it is different. You may work in a primary care where it's in a rural area and you have to get all of these labs. You may work in a different area where your collaborating physician is like, no, send them to rheumatology, or you just don't feel comfortable and you refer them. When you're a new nurse practitioner, it's okay to refer more often. As you get more experienced and you see what the rheumatologists are doing, dermatology, GI doctors, then you say, okay, I can treat this in primary care. You get more experienced with it. And if you're never sure, then we have Up to Date, or you call a colleague and ask them, or you call a rheumatologist themselves and say, this is what I'm presented with. What do you suspect? And they will most likely, I've never had a physician, well, okay, I've had physicians not be necessarily nice, but most of the specialists have been very helpful. What is an anti-dsDNA? It's antibodies called antinuclear antibodies, and if they're produced when your body is unable to distinguish between itself and non-self. So itself and a foreign body, and your body starts targeting, basically targeting your own body. So the anti-dsDNA specifically targets the DNA found within the nucleus, causing the organ and tissue damage. So if you draw that, and if there's a presence of it, it's associated with lupus, an autoimmune disorder, lupus. What are the complements of CH50, C3, and C4? Most commonly, they're used to determine whether deficiencies or abnormalities in the complement system are causing or contributing to a disease or condition. So it's most likely that these complements, through studies, are related to lupus, this autoimmune disease. You can look at the CH50 or CH100. That looks at the entire complement system or pathway. Again, it's a gray area whether you're going to be ordering that or rheumatology. I would say 8 times out of 10, rheumatology will be ordering these types of labs. A direct Coombs test, that's clumping of your blood cells during a direct Coombs test. That means that you have antibodies on the red blood cells, that you may have a condition that causes a destruction of the red blood cells, hence hemolysis. There's different reasons why you can have a positive Coombs test, but you can have, for example, autoimmune hemolytic anemia, but also lupus. It's a transfusion reaction also, where your immune system attacks the donated blood, chronic lymphocytic leukemia, other leukemias, and as I mentioned, lupus, because that's what we're talking about. If you want to know a more systematic lupus workup, or basically what I talked about, here's a really good article that you can go to, which basically goes through what I just talked to you about. So ANA, when to order and how to follow up on a positive test. So the clinician suspects lupus or another rheumatic condition, because remember, sometimes we're not sure what's going on. If you don't suspect it, you're not going to get the ANA testing. If you do, you're going to perform it. And if it's negative, then no further autoantibody testing is indicated. You're just going to follow that patient, and if the symptoms get worse, you may want to repeat it. If it's positive, then that's when you go to further testing, and this is where the algorithm goes. I wish I had a more clear algorithm. I apologize, I could not find one, but the article that I posted is really good, and this algorithm is nice because it'll say if you suspect lupus, but the diagnosis needs to be confirmed, then over here you consider testing for anti-dsDNA and the anti-Smith, correlate with the clinical findings. If you suspect Sjogren's or polymyositis, scleroderma, or connective tissue disease. Again, these things are most likely going to be done in rheumatology, but it's also very important for us to know what direction to go. All right, so let's talk about fibromyalgia, and I did not realize that this would turn out blurry, so I apologize. Fibromyalgia is not just pain. It's a nervous system, what we think is a nervous system issue, and you can have multiple symptoms. This used to be a condition that physicians did not believe in. It's more and more acceptable now. There's still fibromyalgia patients that have a stigma. I believe in fibromyalgia, especially I suffer from migraines, and it's connected. So there's a lot of people out there that have a hypersensitive nervous system, migraines, anxiety, that can relate, depression. And so it completely makes sense why someone can have issues with the muscles, the nervous system, and how it's all interrelated, which ends up causing chronic pain. We don't really even know why, but like I said, I've read a lot of studies, and it seems there's a lot of linkage between patients that have more of a hypersensitive nervous system with neurological issues and or anxiety. And females will get that more than males. And it's usually between ages 30 and 60. Pain, fatigue, they forget a lot. You're tired all the time. Sometimes you can feel your body, your arm or anywhere, and be like, gosh, it feels like it's burned, but I look at it and it's not burned at all. Wake up, oh, I got a numb spot here for no reason at all. Jaw clenching, IBS, headaches, anxiety, depression. 80% of this diagnosis is you listening to the patient's history. There is diagnostic criteria. There's a widespread pain index or a symptom severity index, and this has changed. It used to be where you would have there's like 18 points on your body, and you would have to count, and there was like 11 out of 18 or 9 out of 18. They were positive for fibromyalgia. Now it's a little bit different with diagnosing. So there's this widespread pain index and a symptom severity scale that you use. Generalized pain, defined as pain in at least 4 of the 5 regions. So instead of being a specific point, it's a region. For example, left upper, left right, left lower, right lower, and low back is present. And the symptoms have been present and consistent for at least 3 months. So you don't have to count tender points anymore. I am just going to, hopefully I can get in here and I can show you. All right, so you can click on this link and print it out if you'd like. I love this Diagnostic Scale because it really helps, because when people come in with suspected fibromyalgia, or how people come in that say they think they have fibromyalgia, I think this is a much nicer a screening tool that we can use. So as you can see up here, you count up the number of areas and then you enter your widespread pain index. And then here is the symptom severity score. And there's some other symptoms, and it tells you exactly how to tally them up and what your score means, if it's suspected that you have fibromyalgia or not. Okay, so these are some tender points. We aren't diagnosing using tender points anymore, but people still have tender points. in these areas. The stepwise approach to treatment. First line, okay, let me backtrack. Years ago, they used to be put on narcotics. That's not the way to treat fibromyalgia. And I have had fibromyalgia patients come in upset because they're not getting narcotics. And really, they don't like what I have to tell them, is that exercise really, really helps. And yes, it's really hard getting started because you are in pain, but over time, those pain receptors and the nerve receptors end up healing somewhat. And I don't know the pathophysiology that goes on with that, but exercise really helps. You can also put patients on a low-dose tricyclic antidepressant such as amitriptyline or an SSRI. You can put them on some sertraline, some Zoloft, fluoxetine, Prozac, etc., as well as education. Now, if it's not getting better, that's when they should have maybe a structured exercise program, trigger point injections, acupuncture, stress management, cognitive behavioral program. This is what's difficult with fibromyalgia, because a lot of patients don't want to believe that it's perhaps could be psychological, or it's contributing to it, or exercise is going to help. So I am empathetic that it does cause a lot of pain and it can be debilitating, but try to get them in a pool or try to get them at least walking, because that's really going to help over time. And if I say just trust me, let's give this 3 months, many of them will come back and say that they do feel better. Pain management can also deal with fibromyalgia. But again, pain management is not there to prescribe narcotics. We're really trying to get away from that reputation. And they're there possibly for trigger points, as well as help them with cognitive behavioral therapy. So they're trying to really include all of that in pain management. All right, so I'm going to move on to polymyalgia rheumatica. With this, as you can see, this gives just a picture how you have shoulder and pelvic girdle pain. It happens more in elderly, and many of them have steroids on hand when they start having flare-ups. It's most common over the age of 50, especially Caucasians. It doesn't really cause swollen joints, so it just takes a good history to recognize. If someone has temporal arthritis or giant cell arteritis, it can often occur with someone with polymyalgia rheumatica or PMR. It's worse in the morning and after long car rides, so think about that stiffness. So again, how do you distinguish that from osteoarthritis? Sometimes it can be difficult, and it can take a few visits to even hone that down to find out what's going on. But it is usually limited to the shoulder and hip joints themselves. Aching is stiffness. They can have flu-like symptoms. So when you have osteoarthritis, you're not going to have flu-like symptoms. Pain in the upper arms and thighs. Start at the nearby shoulders and hip joints. You could get a SED rate and CRP to help exclude osteoarthritis, because if your SED rate and CRP are up, that tells me I'm leaning more towards an inflammatory thing, which is what PMR is. They can take NSAIDs, low-dose steroids. It's good to do them in short bursts because you don't want them on it for a long time. I'm sharing this YouTube video here because it's a really good video about the patient with PMR. Giant cell arteritis, otherwise known as temporal arteritis, when you end up getting inflammation in the superficial temporal artery, it can be vision threatening. So it is something that needs to be caught right away and emergent. It's a type of vasculitis. It's an inflammatory, it's an autoimmune issue, inflammation of the blood cells. Which is why it's called temporal arteritis, because it mostly targets the temporal arteries. It can overlap with PMR. So 5 to 15% with PMR have giant cell arteritis, and about 50% of patients with giant cell arteritis have symptoms of PMR, usually over the age of 50. So if anyone comes to my office and has temporal headache and they're over the age of 50, I am suspecting that on my differential list. That's when you get some lab work. I'm not sure why it's changing. Oops. Let me go back. There we go. The SED rate will be very high, and that will prompt me to say this patient probably needs a temporal artery biopsy. So we need to treat this as soon as possible because we don't want them to have vision loss. They can have full vision loss or partial vision loss. You always put them on steroids. You can put them on a low dose corticosteroid. So for example, 40 to 60 milligrams a day of prednisone. You always start it before you even send for a temporal artery biopsy. You just treat them, and if you suspect it, you send them to vascular surgeon or find out where you need to send them. You'll find that their headache goes away pretty quickly because that inflammation is getting better and their SED rate will start to decline, which is a good thing. You can do a higher dose of corticosteroids, but you should taper them down. So usually put them on it for over a month's time. Again, going back to this slide, you put them on 40 to 60 milligrams of the high dose steroids, which I said you don't put them on low dose. I'm sorry, it's high dose. And how do you want to know when you're going to reduce it? That's if they start having symptoms again, or if you notice their SED rate's going up. So these people are going to be constantly monitored with their SED rate. And you can reduce it, and I know it says over a few months. Again, this is just going to depend on the patient. They're usually on it for a month, but again, depending on the biopsy results and how they respond to it, maybe they will be on it for a month or for a few months. And some are on it for longer than that, 1 to 2 years after treatment, because you want to make sure it doesn't come back. These are some really good videos I'd like you to watch. The patient perspective of it, they're short videos. There's more of a fun YouTube video about temporal arteritis. And this is a video, the last one, of a temporal artery biopsy, which is fascinating. And they're all short. Scleroderma is, I'm just going to do a couple slides on this. It's systemic sclerosis, a connective tissue disease, hardening of the skin, hardening of the tissue, which means that it can harden your lung tissue also. So it can be very debilitating, and you can it does have a mortality rate. Commonly, these patients have Raynaud's, and you can see the tendinolextasia, which I can never say that word, on the face. So your body starts making too much collagen, that connective tissue becomes stiff, and it can affect your internal organs, lungs and kidneys. There's two types. There's localized and systemic. Localized is more of just skin changes, whereas the systemic comes on either fast or slow, but it involves the lungs, intestine, esophagus, in addition to your face, hands, and feet. Here's an example of linear versus the morphia scleroderma that you can see on the skin. Here's some differences also between the limited skin scleroderma, the cutaneous, systemic sclerosis versus the diffuse, between the two. So Raynaud's limited, whereas diffuse. So Raynaud's is systemic sclerosis, limited cutaneous. Raynaud's phenomenon for many years, even decades before the onset. Diffuse cutaneous is a recent onset before, after the onset of skin change. So there are some differences between the limited and the diffuse. And if you look here, anti-centromere positive, these are not labs that we're going to be getting in primary care. They'll be going to rheumatology for that.